Hypoxic brain injury is the major cause of death for resuscitated survivors of out-of-hospital cardiac arrest. Could mild targeted hypercapnia, delivered to improve cerebral blood flow, improve neurological recovery? We'll find out on this episode of Osler Shortcuts. Hypoxic brain injury is the major cause of death for resuscitated survivors of out-of-hospital cardiac arrest. While little can be done to treat the primary injury to the brain, avoiding a second hit injury may lead to improved outcomes. Ongoing supply-demand imbalance in the brain may cause the death of susceptible injured neurons, so most recommendations focus on maintaining blood pressure, oxygen saturations, and blood glucose levels in the normal range. The partial pressure of carbon dioxide plays a key role in regulation of cerebral blood flow. In fact, for each 1 millimeter of mercury rise in the PaCO2, the cerebral blood flow increases by up to 2 milliliters per 100 grams of brain tissue. This has led to the hypothesis that PaCO2 can be manipulated to optimize cerebral blood flow. Indeed, there is some early data to suggest this might be true. Observational studies have shown resuscitated survivors of cardiac arrest are more likely to survive with a good neurological outcome and have lower levels of neuron-specific enolase, a measure of brain injury. The TAME study was a multinational, multi-centered, open-label, randomized controlled trial that included 1,700 patients from 63 intensive care units in 17 countries. It included patients who were unconscious between 20 and 180 minutes post-return of spontaneous circulation. All patients had a presumed cardiac or unknown cause of arrest. The trial compared two approaches to carbon dioxide management, targeting the range of 50 to 55 millimeters of mercury in the intervention arm and 35 to 45 millimeters of mercury in the control group for the first 24 hours of their care. The primary outcome of interest was the number of survivors with good neurological outcomes, as defined by an extended Glasgow outcome score of 5 to 8, measured at 6 months. There was no statistically significant difference in the primary outcome, with 43.5% and 44.6% of patients having a good outcome at 6 months. Mortality at 6 months was also unchanged, as were health-related quality of life measures and complication rates. TAME is a very well-conducted trial, run by experienced critical care researchers, and is the second largest trial in post-resuscitation care to be published so far. It has a strong methodology and has broad generalizability in high-income countries, and provides convincing data that mild targeted hypercapnia is not effective. However, as always, there are some things to keep in mind when reviewing these results. Firstly, there was a moderate amount of loss to follow up, with the primary outcome available in only 92.4% of patients. Secondly, the median time to commencing therapy was 2.5 hours after resuscitation, which may mean that any potential benefit is delivered too late. Thirdly, the trial was powered to have a 90% chance of detecting an 8% absolute increase in the primary outcome. This seems ambitious, and smaller improvements would certainly be considered significant. Fourth, there are some concerns about whether or not the groups were properly separated, with patients in the intervention group achieving their target range for just 7 hours, while the control achieved it for just 4. Finally, TAME delivered the therapy without any monitoring of cerebral perfusion, nor did it routinely invasively monitor for raised intracranial pressure. It may be that in the future the use of such monitoring could help better identify patients at risk and detect complications earlier, which may tip the balance in favor of the approach. All that said, all the point estimates favor normocapnia, so it seems unlikely mild targeted hypercapnia could be beneficial if applied in this way in this group of patients. Thus, TAME becomes yet another trial which has explored manipulation of important physiological variables after cardiac arrest to show no benefit, including temperature, blood pressure, and oxygen targets. If you like this summary and would like to know more about the TAME study, head on over to Osler and check out the full review. Like all Osler content and features, it's completely free. See you next time on Osler Shortcuts.